As we say, the multiple sclerosis, it is a progressive inflammatory demyelination and neurodegenerative disease leading to the chronic disability in the most of the patient, and we say that more than 2.3 million people are affected worldwide, and the peak age is about 13 years. The adolescent is less than 5% are affected, and the less than about 9% over the 15 years of the age. 2 to 3, the female are more affected more than the male. The most of the patients are within the 20 years will lead to the eventually develop the substantial cognitive deficit. The precise cause is until now it's unknown. The complex genetic trait it seems to be contributed to the disease, and the infectious factors such as Epstein-Barr virus and the vitamin D level also contribute to the disease. It showed that the risk of the children of multiple sclerotic parents are 10 to 20 times higher than the general population. The clinical course of the disease, the first relapse are remitting multiple sclerosis. This account about 85% of the all patients. The new neurological deficits are typically developed over the period of the hour, and they then reach a plateau. The subside over the week or the month. The attack is lasting about more than the 24 hours. The clinical form typically presented with an acute clinical isolated syndrome attributed to the monofocal or multifocal CNS demyelinated disease. The site of predilection of the disease are, as we say, the optic nerve of large white matter area, hemisphere, corpus callosum, cerebellum, and cerebellar peduncle pons, and the spinal cord. The recent histological studies are show that the cortical gray matter also may be affected. All of the CNS lesions present with variety of symptoms of the sensory disease, sensory or muscle weakness, visual disturbance, cognitive, and even the psychiatric symptom may be seen. The presence of this lesion affected the optic nerve, causing optic neuritis in the spinal cord, causing transverse myelitis, and in the brainstem ophthalmoparesis. The second type is the secondary progressive multiple sclerosis. In 70 to 80% of untreated patients of the relapse remitting multiple type replaced by the remitting course eventually convert to the secondary progression disease, which is associated with steady increase in the disability, and this will be over the 10 convert over the 10 years. The primary progressive multiple sclerosis is at 10 to 20% of patients. This disease begins at the primary progressive neurological deterioration with or without a superimposed attack of the disease. This form of multiple begin as a progressive disease with occasionally plateau and relapse. The temporary minor improvement will be seen, which is and it is a poorest prognosis compared to the other type. The clinical factor that, as we say, is more suggests that more favorable of the disease course is the early onset of the initial symptom. Like the visual disturbance of the initial presenting symptom. Relapse occur within the period of remission, and the female gender are the favorable character. Factor that predicting the less favorable course of the disease is the later onset of the symptom with the cerebral symptom and pyramidal tract sign, automatic dysfunction, and the occurrence of the severe attack of and also the male gender is the less favorable course. Overall, 1/3 of the patient will not express the significant disability in their life, and 1/3 will have the cumulative neurological deficit, but can still lead to an independent life and independent life. The 1/3 of the patient will develop the level of disability that require nursing care. Treatment usually, because it has no any causative factor, but still the high dose corticosteroid and the immunomodulator agent and some of the drugs may help the patient. The normal nerve fiber and the central core of the fiber conduct the action potential for the cell movement. The fiber is surrounded by the myelin sheath made up of the lipoprotein. The sheath insulated the fiber for the better nerve cell transmission. The myelin sheath is so thick that almost no ion can flow through it. They must be transmitted through the node of Ramberg, which occurs once every 1 to 3 seconds along the sheath. This node creates a saltatory conduction, which is allow the nerve impulse to jump along the fiber in succession. This is the nerve fiber. As you see, there is the Schwann cell causing the myelin sheath around the nerve axon with some node of Ramberg, which is causing the action potential to transmit the nerve impulse.
أشر بابا ليش ما أشرك عليها؟ أرجع شارج.
نعم.
وعلى كيفك ابني، أنت بدك تقرأ كأنما بدك تقرأ لنفسك. أنت عندك أودينس 90 أكثر من 90 واحد. وصل نعم. الفكرة يا ابني. أشر على هذه أيدا هذه.
بس ما أعرف شلون أسوي شو اسمه دكتور. يعني ما هي هذا
طلعت الليزر.
This is node of Ramberg, and this is the yellow one is myelin sheath. This node of Ramberg, I have the explanation for the nerve impulse, how it's affected by the multiple sclerotic patient in the next slide. This myelin sheath. So this is the explanation of this is the explanation. This yellow, this is the myelin sheath. The nerve impulse, it is produced inside the neuron, will form a high positive intra-axonal pressure, which lead to the opening of the port of Ramberg, node of the Ramberg, with impulsion of the sodium to mediate the action potential inside the nerve, which lead to the increased speed and faster transmission of the impulse. If what happened in the multiple sclerosis is destruction of the destruction of the myelin sheath would lead to the decrease of the intracellular positive charge and subsequent leak of the subsequent leak of the intracellular positive charge, and this will lead to the suppress the action potential inside the cell, and this lead the loss of the signal in the nerve, and even the pulse will not reach not transmitted through the nerve. This is the myelin. This is this is the nerve cell with myelin, normal myelination or myelin. The second image is destructive myelin, with show the distortion of the message and even slow down the message through the transmitted the axon. Diagnosis is how it is mainly the clinical based and paraclinical. The history examination is one of its most important evidence of the CNS involvement. Dissemination in space, neuroimaging is supportive for the diagnosis. What is the dissemination in space? Is the objective evidence of the neurological deficit localized to two separate parts of the CNS. What is the dissemination in the time? It's the onset of the neurological deficit separated by the last at least 1 month. And these two criteria, these two disseminations should be present in the multiple sclerotic patient and rule out the other explanation until prove the multiple sclerotic patient. The primary progressive multiple sclerosis may diagnose in patient with 1 year of disability progression retrospectively or prospectively determined in independent clinical relapse plus 2 out of the 3 of the following criteria: more than 1 lesion due to hyperintense lesion in the one area of the brain, characterized of the either in the periventricular, cortical, juxtacortical, or infratentorial region, more than 2 T2 hyperintense lesion in the spinal cord, and the presence of the CSF specific oligoclonal bodies. Diagnostic tool is the examination in the CSF as presence of the oligoclonal antibody seen in about 85 to 90% of the patient with multiple sclerosis. It is an high elevation of the total IgG and elevated IgG ratio. It's oligoclonal antibody in the serum. It is not present, while in the CSF examination of the effect in the multiple sclerotic patient is present. Dissemination in time. What's the dissemination in time? Is required more than 2 lesions in 2 or more of the following: either in periventricular, juxtacortical, infratentorial, or spinal cord. And dissemination in the time, detection of the T2 lesion in the gadolinium or in gadolinium enhancing lesion in respect of the time, or simultaneous presence of the 2 lesion enhancing lesion and a non-enhancing lesion. It's called a dissemination in time. These are criteria for the diagnosis of the multiple sclerosis. And radiologically, magnetic MRI is the main diagnostic modality for the examination or the diagnosis of the multiple sclerotic patient. Usually, most of the sensitive image technique for the detection of multiple sclerosis plaque throughout the brain and the spinal cord. T2 flare attenuation, inversion recovery, image show area of high signal intensity in the periventricular white matter in 90% of the multiple sclerotic patient. This signal increase indicate the edema or inflammation and demyelination in the acute phase, or gliosis or axonal loss proportion to the differ from the usually occur in the chronic case. Specific region of the central nervous involvement is periventricular white matter, callosal septal interface, juxtacortical white matter, other region, pons and cerebellum and spinal cord. Gadolinium enhancement MRI is required for the reference standard to detect active inflammation lesion in the multiple sclerosis, identify disease activity in 5 to 10 times more frequent than the clinical evaluation of the relapse. It means that the MRI for detection of the relapse is more sensitive than even the clinical state. The technical examination for the multiple sclerosis, the conventional proton density, T1 weighted and T2 children clinical sequence are generally sufficient for the standard clinical and supported multiple sclerotic patient. The present lesion in the juxtacortical white matter, the axial slice usually require across the whole of the brain flare examination. In the juxtacortical white matter, the proton density and T2 are insensitive for the detection of the lesion in the juxtacortical, while the flare is the mandatory for the lesion in this area. But what's the disadvantage of the flare? It's not suitable for the posterior cranial fossa and the upper cervical. In T2, we have T2 spin echo required in the examination of the relapse limiting to detect the black hole, which is all lesions that appear in the parenchymal deficit. Because of the black hole are also detected after the contrast administration. it is the practice at the same require the three-dimensional T1 data at isotopic in the thin section, at least 3 millimeter. Other modality, other sequence for the detection of the diffusion weight limit. A new technique is magnetizing transfer magnetic resonance spectroscopy has a great role. Double inversion recovery is also acceptable. Image also is required for the diagnosis in the lesion. T2 lesion in the how it is appear in the T2 the lesion how it's appeared. Multiple hypertense appear at the multiple hypertense lesion in T2 proton density sequence characteristic of the multiple sclerosis. Lesion usually small or reached several centimeter, round or oval acute T2 lesion may show a halo of less striking hyperintensity, probably consists with the edema that resolve over the time, and they raise their final size within the 6 months. A T2 lesion have a specific value in prediction of the outcome of the patient presenting with the clinical isolated syndrome. Clinical isolated syndrome with normal cerebral MRI presentation, we have a 11% risk of another attack in the next year, with where the if 2 or more cerebral lesion had the high risk in the 90% of the attack. Change in the number and the volume of the T2 lesion has been used to surrogate the marker in the clinical trial in the new therapeutic agent. This is the T2 image, how the lesion is appeared in the deep white matter. It is round and perpendicular to the subendomal. Also, it is important, it is seen in the subjuxtacortical, in the posterior fossa occipital, in the frontal area appear and the high signal in the lesion. Also, it is in the posterior fossa in the midbrain, and easily detected by the T2 lesion. Flare also is another sequence. This is more prevalent in the periventricular area. The flare are increasing the consequence. The more important in the periventricular area. The tissue water is also affected